Hi class, this is our second installment. We are continuing our lecture on disorders of the endocrine system, and I'm going to start this second part by discussing some of the actions that thyroid hormone can have on target cells. There are many, and again, each target cell or tissue or organ is a target because it has a functional receptor. And each of those targets are going to behave in their pre-programmed way. As I said earlier, a heart will behave like a heart should. The brain will behave like the brain should. And it's because of their unique gene expression. For the gut, there will be increased gut motility. So someone who has a lot more thyroid hormone than they should is going to be complaining of constant diarrhea. The thyroid hormone also stimulates neuronal cells, so the person is going to have increased mental activity. It doesn't make them smarter, of course, it just means more action potentials. It excites the central nervous system. This can mean that in some people it leads to sleep difficulty because they can't turn off their brain, quote unquote. They just can't seem to put their day to bed. They keep thinking and worrying about something. Now, in a fetus, thyroid hormone comes from the mother. It crosses the placenta, and it's very important to have enough thyroid hormone to stimulate the development of the neurons, and not only that, but to help encourage synapses, so the connections between neurons. And this is also, again, important to continue the process even after the fetus is born. Thyroid hormone stimulates fat cells and increases lipid mobilization, and that means you're using those fats as fuel. That may sound like it's a wonderful thing and that everyone should use thyroid hormone extract to lose weight. However, to remind you, this is part of a feedback mechanism, and no, you shouldn't be taking thyroid hormone extract or thyroid extract. I had a student that actually was taking horse thyroid extract, and when she stopped taking it, it had a lot of impact on her body. She went from being very, very thin to morbidly obese. So I discourage you from messing with this HPT pathway. The thyroid hormone also stimulates the sodium-potassium ATPase. It increases the activity of that pump. And whenever we have something that uses ATP, heat is lost as a byproduct. So there is a thermogenic effect. The person's body temperature will go up. Shown here on the slide, you also see that there are cardiovascular targets. In particular, the force of the heart contraction, known as inotropy, and the heart rate, known as chronotropy, both increase, as does the respiratory rate. So does blood flow. And over in the far right of the picture, you can see the effects that thyroid hormone has on metabolic rate. Pretty much everything goes up. Gluconeogenesis, glycogenolysis, there's mobilization of nutrients, basically. Membrane transport goes up, basal metabolic rate goes up. Just a lot is happening on a metabolic level when thyroid hormone levels are around. Keep this in mind as you start to appreciate some of the people I'm going to be talking about with thyroid disorders. If they have too much thyroid hormone, they have hyperthyroidism, and if they have too little, they have hypo. What would you predict to see for their signs and symptoms, knowing this picture, this slide, as your starting point of what to expect? So let's start with hyperthyroidism. In addition to the 3 examples I gave you in the previous segment, where we had over-secreting tumors of either the hypothalamus, the anterior pituitary, or the thyroid itself, here is yet a 4th way someone can have hyperthyroidism, and this is called Graves' disease. This woman likely has a higher metabolic rate. She's likely slender and thin from having an increased metabolic rate. She probably also has fine muscle tremors because thyroid hormone stimulates skeletal muscle contraction. You can notice her bulging eyes here. That's exophthalmos. The reason why she has this is because she has antibodies from B cells that are called thyroid stimulating immunoglobulins. So they are antibodies. And this technically means that Graves' disease is an autoimmune disorder. Now, her antibodies are not attacking and destroying her thyroid gland. Instead, her antibodies on the thyroid gland, they are binding to the receptor for thyroid stimulating hormone. And you can even notice, if you look carefully in this picture, she does have a goiter. And I'm going to talk more about how goiters occur in just a moment. So just hold off on that for right now. But she does have a goiter. She has hyperthyroidism. Let's go through this disrupted pathway. But I assure you, as we continue on to other disorders, I'm going to expect you to be able to draw the normal pathways as well as the disrupted pathways. I've shown you some examples for the thyroid system, the HPT. The same rules apply for other axes like the HPA, hypothalamus pituitary adrenal gland axis, that I'm going to talk about in just a moment. So remember, the hypothalamus releases TRH, and the anterior pituitary, the thyrotropes, have receptors for TRH. The hypothalamus, just to remind you, also has receptors for its own hormone. That is how it quantifies how much hormone was released to target the anterior pituitary. That's a short feedback loop that we talked about in the previous segment. The anterior pituitary releases TSH, thyroid stimulating hormone, and the thyroid gland has receptors for that TSH. Now the thing is, with these antibodies, and I'll draw them in a different color, say this rust brown color, they can bind to the same TSH receptors, even though they are not TSH. They have the same fit. To the thyroid gland, that's all it knows. All it knows is its receptors are populated. It's receiving a command. I'm not trying to anthropomorphize, but I'm trying to talk in a story so you can follow this pathway. So the thyroid gland starts to produce a lot of thyroid hormone, which is both T3 and T4, as we learned in the previous segment. Now feedback, the long feedback loop. All of this thyroid hormone is going to negatively inhibit the hypothalamus. This in turn will decrease TRH levels or TRH release. This means that the thyrotropic cells in the anterior pituitary won't have their TRH receptors populated, and that means to them they should not release TSH. In a healthy system, the lack of TSH should shut down the release of thyroid hormone from the follicular cells, but it does not. So this is negative feedback inhibition failure yet again. Those TSIs keep binding to the TSH receptor on the thyroid gland. She has a goiter. A goiter results from both hypertrophy and hyperplasia of the thyroid gland. And if you remember your cell adaptation, injury, and death lecture, you should know the difference between hypertrophy and hyperplasia. We get both in the thyroid gland. It gets bigger, and that explains the enlarged thyroid gland. Okay, you're going to see on the next slide that a goiter is not a diagnostic tool. you might predict that a goiter only happens in a person with hyperthyroidism, but on this slide, you're going to see that it can happen for a person who has hypothyroidism. In addition to the 3 ways that I told you a person can have hypothyroidism, from an under-secreting tumor that I went through in the previous segment, we also can have a person with hypothyroidism if any step involved in making thyroid hormone has been compromised, whether it be the gene expression of the thyroglobulin protein, whether it be the membrane transporters that move the thyroglobulin into the colloid space or endocytosis back in. It might be the iodinase, it might be the peroxidase, any step involved in the synthesis and modification of thyroglobulin and thyroid hormone, if defective, can lead to hypothyroidism. Iodide deficiency, the lack of iodide. Here's my analogy for this. If you want to make chocolate chip cookies, you have all of the ingredients. You've got eggs, you've got flour, you've got sugar, baking soda, etc., but you don't have chocolate chips. Well, you can still make a cookie, some sort of cookie, but you can't call it chocolate chip cookies if you don't have chocolate chips. So these follicular cells can go through the process of making thyroglobulin and putting it in the colloid space. Colloid, by the way, means a proteinaceous soup, an aqueous solution filled with a lot of protein. You can go through the whole process, but unless you have iodide to attach to those tyrosine residues in the appropriate amounts, you're not making thyroid hormone. So those follicular cells will release something, but it's not thyroid hormone. This lady on the right has an iodide deficiency. We call that an endemic goiter. So she doesn't have enough iodide in her diet, and you can see the goiter that she has, and yet she has hypothyroidism. This lady on the left, she has Hashimoto's thyroiditis. It is also an autoimmune disorder that we learned about with Graves' disease, for example, but the antibodies in this case behave very differently with Hashimoto's. The antibodies actually attack and destroy the follicular cells. Now notice that she too has a goiter. How can that be if I just said that her antibodies are destroying her thyroid gland? Most students predict that her thyroid gland would get smaller instead of larger. Well, there are 2 ways to get a goiter, 2 ways. One we saw in the previous slide was to have TSIs, antibodies that are binding to the TSH receptor and stimulating it, overstimulating the follicular cells. Now, how is it that these 2 ladies on this picture with the goiter, the iodide deficiency woman and the Hashimoto's woman, how are they getting a goiter? They have increased levels of TSH. Why? Well, draw the disrupted pathway. That's your job. If this woman is releasing something from the follicular cells, but it's not thyroid hormone, if those levels are going down, feed back to the hypothalamus. What would the hypothalamus do? It's going to try and increase the system. Its release of TRH will go up, and the amount of TSH will also go up. And that's going to keep stimulating those follicular cells. Here comes the hypertrophy and the hyperplasia. What about this woman with Hashimoto's? Well, as her antibodies are attacking her follicular cells and destroying them, her thyroid hormone levels are going down. And as her thyroid hormone levels go down, feed back up to the hypothalamus. The hypothalamus's receptors are not going to be as well populated. And to the hypothalamus, that means it needs to increase this pathway's production of thyroid hormone. So TRH levels go up. TSH levels also go up. And for the remaining follicular cells that have not been destroyed yet, there is going to be an increase in their size and activity. And here comes the goiter again. So I would be ready for questions on these hormone pathways that are disrupted. And I would also be ready to explain this in your exam questions when and if you reply or respond to the endocrine questions. So the baby in the middle here has also hypothyroidism. And the baby is sadly having mental deficiency for the rest of its life. And the reason is the mother, while she was pregnant, did not make adequate thyroid hormone. And a couple slides ago, you learned what thyroid hormone does for prenatal brain development. So the lack of thyroid hormone leads to a mental deficiency for this infant for the rest of its life. The woman on the left, just to go back and point something else out here, in addition to her goiter, look how puffy her face is. She has edema, but not pitting type edema. She's got mixed edema. So if you pressed on her face, you would not leave an indented region where your finger pressed on her. And this is because she has a lot of water retention from the changes in her extracellular matrix in her dermis. And again, that's because of the lack of the thyroid hormone. So that's what's called mixed edema. And here is a chart that talks about, in the center column of this chart, you're seeing some of the target systems, enzymes, cells that I talked about at the beginning of this second session. And on the left, you're seeing what will happen in the person with hyperthyroidism. And in the case of Graves' disease, you're seeing here one of the signs is the exophthalmos. And on the right, on the third column, you're seeing what you would expect to see in a patient with hypothyroidism. I would definitely know these signs and symptoms from this chart, especially I would review them quite well before you start taking your quiz or before your exam. And this slide is basically showing you some of the ways a person can be hyperthyroid or hypothyroid. Many of these I've already addressed. I'm just putting them in an itemized way. We can have an over-secreting tumor of either the hypothalamus, anterior pituitary, or thyroid itself. The person can have Graves' disease. All of those can lead to hyperthyroidism. Hypothyroidism, it seems like there's a bigger list. We can have an under-secreting tumor of the hypothalamus or anterior pituitary or thyroid gland, an iodide deficiency, a problem with gene expression for any of the proteins involved in the synthesis of thyroglobulin and manufacturing a mature thyroid hormone. A person can also have Hashimoto's thyroiditis, or maybe there was a maternal deficiency of thyroid hormone when there was a fetus developing and now it has mental deficiencies. So this is also a good list to know before you start taking your quiz or your exam. Now we're moving on to the HPA pathway. I'm going to take a couple of minutes to quickly review the adrenal gland, its anatomy, and some of its physiology before we focus on the actual part of the adrenal gland that participates in the HPA pathway. The adrenal gland is a mixed gland. It's actually two different endocrine glands that had different embryological origins. In the very middle of the endocrine gland, shown down here in the darker brown color that I'm highlighting with my purple pen, is the adrenal medulla. That is actually an extension of the sympathetic nervous system, your fight or flight response. And that part of the adrenal gland releases primarily epinephrine. Epinephrine is mostly used as a hormone, but it can also be used as a neurotransmitter. And I talked about that before when we were discussing hormones that are tyrosine derived. Now, the adrenal cortex is this larger layer, shown here in yellow, around the adrenal medulla. It's the bulk of the adrenal gland. And it's organized into 3 layers. Let's explore those 3 layers now. The adrenal cortex has 3 layers going from superficial to deep. They are the zona glomerulosa, zona fasciculata, and the zona reticularis. If you're reading a good physiology book or a good pathophysiology book, they would be listing for you all of the different types of hormones released by these 3 layers. For testing purposes, we're going to reduce that long, lengthy list and focus on 3 hormones. 1 hormone from each layer. Now, that's not the exact truth, but it is a close approximation, and it reduces a lot of confusion during testing if we adhere to this system of mine. So I want you to know that the zona glomerulosa releases a mineral corticoid, and the primary mineral corticoid is aldosterone. And I want you to think of aldosterone as just a mineral corticoid. It is going to target the nephron of the kidney. It will stimulate the secretion of potassium, and it will also lead to more sodium and water retention. That's why it's called a mineral corticoid. We will talk about problems with aldosterone in a different lecture when we talk about electrolyte imbalance. It will not be focused on in this lecture on endocrine disorders. Though I could have put it here, I just find it fitting when we get to our kidney section of the course. The zona fasciculata releases a glucocorticoid called cortisol. Now again, I want you to just think of cortisol being released by just this layer, and I want you to think of cortisol as just having a glucocorticoid effect. And that means it's going to target plasma glucose levels. It's going to increase plasma glucose levels, and I'll explain why in just a moment. It will also stimulate other mobilization of other alternative fuel sources like protein and fat. And again, I'll show you on another slide how and why this occurs. Cortisol is the only hormone I am going to talk about from the adrenal cortex that obeys a hormonal mechanism for release. And it is the only hormone that obeys the HPA pathway, the hypothalamus pituitary adrenal gland. And I'll show you this pathway in just a moment. Now, the last layer, the zona reticularis, releases a male steroid hormone. And when it's a male steroid-like hormone, we call it an androgen. And this hormone we just abbreviate it as DHEA. And I'll show you a picture of this pathway in just a moment. DHEA and aldosterone, just to say it again, do not obey a hormonal pathway. They have nothing to do with the HPA pathway. Instead, the mechanisms that trigger their release are going to be humoral. That means something in the plasma triggering the release of aldosterone and DHEA. So that is not going to be our focus for the discussion on the adrenal cortex. I want us to focus mostly on the HPA. The hypothalamus is going to release corticotropic releasing hormone. That's what CRH stands for. Some textbooks call it CRF for corticotropic releasing factor. This will stimulate the corticotropes on the anterior pituitary, and they will release a hormone called adrenocorticotropin hormone, ACTH. And this hormone has a unique synthesis, ACTH. I'm going to talk about adrenocorticotropic hormones synthesis in just a moment. But when ACTH is released, then the zona fasciculata responds to it and releases glucocorticoids, specifically cortisol. And as cortisol levels go up, of course, there are negative feedback inhibition loops. As I said before, the same rules apply to this feedback system as they did for the thyroid gland. Once you learn the rules for one HPX pathway, you learn the rules for all of them. So what does cortisol do for us? What are the effects? First of all, too many times I hear cortisol being labeled as that, quote, nasty little stress hormone, unquote. Cortisol is essential for life. Without it, you can die, because without it, in between meals, your blood glucose levels would decline to such low quantities that your brain would not have adequate fuel. Yes, cortisol is a hormone released in response to chronic stress. You see, epinephrine is released when you have acute stress. What are examples of acute stress in your daily life? Well, it might be you slamming on the brakes and nearly missing having a traffic collision. Or maybe someone turned the corner in your house and scared you. You know, you got your fight or flight response. That's short-lived, or at least it's supposed to be. But in our human lives, unfortunately, we have chronic daily, monthly stress. We have stressors in our life that follow us for many days, weeks, months, or even years. And as such, instead of a sympathetic response, your endocrine system takes over. So cortisol, what does it do when it's being released as because you're under a lot of stress? And stress doesn't have to be you worrying about your mortgage. Stress can come in the form of maybe it's a child going through growth, going for a while in between meals. Let's say you haven't eaten in 6 hours. That to your body is interpreted as a long-term stress. So anything that's long-term, we get more cortisol being released. Cortisol will target skeletal muscle. And when it targets skeletal muscle, it will lead to proteins in the skeletal muscle being depleted, being broken down, and the amino acids are released into the bloodstream, shown here, and they will travel to the liver. Some amino acids can actually be converted into glucose. It's weird to think that we can take an amino acid, which is a protein precursor or monomer, and turn it into a carbohydrate. That is a totally different molecule. Using alternative fuels to make glucose is a process called gluconeogenesis. Gluco for glucose, neo means new, genesis means to make. So the liver has this amazing ability to take amino acids or fatty acids that are released from adipocytes and adipose tissue and convert it to glucose. So we see mobilization of proteins, we see mobilization of lipids. They go to the liver, and the amino acids and fatty acids and glycerol are used to make glucose, gluconeogenesis. Cortisol also tells cells of the body that are not neurons, so anything that's not nervous tissue, cortisol tells those cells, hey, don't use glucose as a fuel. Save that for the brain. This body is under a lot of stress, and our brain needs to figure out a way out from it. So because of glucose being spared for fuel for the brain only, because we also see gluconeogenesis, we say cortisol has a diabetogenic effect. If you were to draw blood from a person that has hypercortisolism, you would see elevated plasma glucose levels, and you might mistake it for maybe they have diabetes mellitus. They don't have a pancreas problem. They don't have an insulin problem. They have a cortisol problem. So we say diabetogenic effect, diabeto-like effect. Cortisol also decreases your T cell and B cell populations. And that means you're probably going to be more susceptible to infectious agents. You're going to get sick. Ever notice after a typical 16-week semester, when it's finals time, you typically get sick? It's because you've had 16 weeks of chronic stress. Your cortisol levels have been going up. Your T and B cell population has been going down, and now you are susceptible to an opportunistic infection. We actually use this effect on the immune system to our benefit in a clinical situation. Some people have chronic inflammation, and with chronic inflammation, you will learn this, we have some T cells that behave badly, and they end up causing a lot more damage than the help that they're supposed to be bringing. With chronic inflammation, say in a disease like rheumatoid arthritis, having a person on a good dose of cortisol, and sometimes this has a different name like prednisone or prednisolone, having them on that prescription long term will help decrease that T cell number and response and helps their chronic inflammation. You'll learn more about inflammation in another lecture. So again, I would know these effects of cortisol on the target cells. Something else that I should discuss before I move on with this slide, if you're under chronic stress, non-essential functions of your body will also be suppressed. If your body could talk to you, it would be, hey, we're under so much stress, probably now is not a good time to conceive. So reproductive health declines. Women under chronic stress oftentimes have a hard time getting pregnant when they want to. Sometimes that's the reason why the OB-GYN might recommend to the woman, hey, go take a vacation. Take a vacation with your honey. Maybe that will help you get pregnant. Another non-essential function of the body that can be suppressed is growth. So a lot of children that are physically or mentally abused have short stature. And it's not because they have a growth hormone problem. It's because the cortisol levels are so high in them, and it leads to a suppression of non-essential functions. Growth isn't really essential. So just something to think about as we talk about some of the signs and symptoms of hypercortisolism. Now let's address the pathophysiology of the adrenal cortex, specifically the zona fasciculata, the layer that releases cortisol, because that's the only layer that obeys the HPA pathway. I want you to look at the pictures here on this slide. This woman has Addison's disease. Look how dark her skin looks. You might make a prediction about her ethnicity, but you would be surprised, I bet, when I tell you that she's of Irish descent, very, very fair complexion under normal circumstances, and yet it doesn't look like that in this picture. She has hyperpigmentation due to her primary adrenal insufficiency, also known as Addison's disease. In primary adrenal insufficiency, all three layers of the adrenal cortex can be destroyed or atrophied for various reasons. Maybe it's an autoimmune disorder, maybe because there is an infection like tuberculosis that attacks the adrenal gland. So if all three layers of her adrenal cortex are compromised, what would you expect to see? Well, she wouldn't be making and releasing aldosterone in sufficient quantity. She would not be able to retain sodium and water, so she would have low blood volume and pressure. She would not be able to secrete potassium. That means she would have elevated potassium in her blood. That's hyperkalemia. What about the next layer? She would not be releasing cortisol. That means going between meals for a long time can be life-threatening because her blood glucose levels are not being adequately maintained. You see, glucagon isn't always enough to maintain your glucose levels in between meals. She's going to have a problem with releasing DHEA. That's the male androgen hormone I told you was made and released by the internal layer, the zona reticularis. Now, what does DHEA do for men? Not much. Men, their primary androgen is testosterone. That's where they get most of their secondary sex characteristics. But for women, DHEA gives us amazing things like pubic and axillary hair. So in this woman, because she has a decrease in DHEA, her pubic and axillary hair would be sparse. Sounds like a great way to save some money on your bikini wax, doesn't it? Now, you should be able to draw the disrupted pathway. If cortisol levels are going down in this woman, feed back. What would happen to CRH levels and ACTH levels? Would they go up, trying to rev the system up, or would they go down? They're going to go up. And when the ACTH goes up, that explains why we see the hyperpigmentation in this woman. I'll go through the actual molecular reason in just a moment, and I do expect you to know why hyperpigmentation occurs. Before I do that, let's address secondary adrenal insufficiency. Secondary adrenal insufficiency occurs because you're not having enough ACTH stimulating the zona fasciculata. Maybe there is a underproducing tumor in the anterior pituitary, and those corticotropes can't release enough ACTH. Or maybe the person had rheumatoid arthritis. Maybe they were given high doses of cortisol. This is an exogenous pill, an exogenous medication. That means their endogenous HPA pathway would go down. This is a similar type of example that I gave you with the birth control pill. And as their endogenous levels go down, their endogenous production of cortisol obviously declines. If they stop taking that pill, that cortisol pill, all of a sudden, then they won't have enough cortisol in their system to maintain adequate blood glucose levels between meals. They will have what's called an Addisonian-like crisis. Again, Addisonian-like crisis, not able to maintain adequate blood glucose levels between meals. Aldosterone levels in secondary adrenal insufficiency might be okay, normal even, no hyperkalemia or hypotension or hyperpigmentation, because there isn't, well, first of all, let me address the no hyperkalemia, no hypotension. Aldosterone does not follow the HPA pathway. So if there isn't enough ACTH, that's not what stimulates aldosterone to be released. It's humoral, it's potassium levels, it's the renin pathway, and you'll learn more about this in another lecture. This person with secondary adrenal insufficiency wouldn't have hyperpigmentation. They're not having enough ACTH. So perhaps now is a good time to explain why hyperpigmentation occurs in the first place with this woman, this person that has primary adrenal insufficiency or Addison's disease. Okay, so the corticotropes in the anterior pituitary respond to the hypothalamus hormone called CRH, corticotropin releasing hormone. And when the corticotropes make and release ACTH in response, you need to know that first they make a large protein called POMC. It stands for pro-opioid melanocyte corticotropin. It's a very big protein. And from this protein, the cells in the anterior pituitary can make two choices. They can either cut from it, from one section, they can cut from it a section which will become melanocyte stimulating hormone. Melanocyte stimulating hormone tells you what it does. It's going to stimulate melanocytes. You will have more pigment production. You're going to look tan. Sounds a little familiar to that woman whose pictures I showed you on the previous slide that was hyperpigmented now, doesn't it? Or another choice they might have, instead of clipping out melanocyte stimulating hormone, these anterior pituitary cells might cut the protein differently and release ACTH, adrenocorticotropin hormone. And you can see from my picture that there is an area of overlap. So if a person releases more ACTH, then they have a lot of that hormone with just a little bit of it that has this overlapping MSH-like property, and that's enough to stimulate those melanocytes, and that is the reason why we get the hyperpigmentation. So anytime in your disrupted pathways, if you read or figure out that there's an increase in ACTH, also start to expect to see some changes in the pigmentation of that patient. All right, now let's move on to excessive adrenal hormones. Cushing's disease is an overproducing anterior pituitary tumor. That means we have excessive ACTH, hello pigmentation, and this will lead to more cortisol release, hypercortisolism. What would we expect to see? Increased blood glucose levels, muscle wasting from the mobilization of the proteins from skeletal muscle, fat stores being depleted. Look at the muscle wasting in this person here in the picture. Cushing's syndrome is not an anterior pituitary problem. Cushing's syndrome still leads to hypercortisolism, but can be caused from a myriad of sources. One might be, maybe the person has an over-secreting adrenal cortex. Maybe all three layers are overproducing. What would we see? Well, let's start with excessive cortisol. With excessive cortisol, we're going to see a huge increase in blood glucose levels. We're going to see big time immune suppression. Those T cells and B cell numbers are going to go down. Mobilization of proteins. In addition to muscle wasting, shown in this person's picture, we're also going to see collagen being used. Collagen's a protein. You can see the striae, the stripes in this man's abdomen. That is from the mobilization of collagen, using the collagen protein for amino acids. And this also means the thickness of his dermis is going to go down. So he's going to have thin skin plus these striae. We don't see his face, but his face looks perfectly round. We say moon face. This isn't from edema, rather it's just a change in the extracellular matrix of his face from the cortisol. And you can't see in this picture, but if he turned to the side, he would have a lot of fat deposition between his scapulae. He would almost look like he has kyphosis, but it's not a skeletal deformity, it is a fat deposition, so we call it a buffalo hump. If the other layers were overly secreting, what might we expect? More aldosterone. So if that happens, we would expect increased blood volume and blood pressure from too much sodium and water retention. We would see hypokalemia from too much secretion of potassium. And for the last layer that releases DHEA, well, if it's a man, you wouldn't really expect too many problems because testosterone is their primary androgen. But in a woman, a lack of DHEA would lead to sparse pubic hair and axillary hair. To determine if a person has Cushing's syndrome or Cushing's disease, a dexamethasone test is done. Dexamethasone is another kind of glucocorticoid. And you do two different tests. One is a high dose of dexamethasone and one's a low. This test is done in the evening overnight, and the high versus low is basically to see if the person with a high dose will exhibit some negative feedback inhibition of their own endogenous cortisol. So we use those two levels of dexamethasone to see if there is any negative feedback response at all. To finish up on Cushing's syndrome, another reason why someone might have Cushing's syndrome is because it's physician-induced or iatrogenic. It means they're on a prescription. So if it is physician-induced, we would expect to see high levels of cortisol, but not necessarily high levels of aldosterone or DHEA. It is just the cortisol being prescribed. Now, another interesting issue with the adrenal glands is called congenital adrenal hyperplasia, or CAH. This is a genetic disorder. It can be caused from a genetic mutation in quite a few different steps for the synthesis of these hormones, and I'll explain on the next slide. But there is no easy way to say, will this child have a lot or a little of aldosterone? So I'm going to start with that bullet here. Mineralocorticoids, like aldosterone, can be excessive or deficient. Don't spend too much time on that. Why? Here's the take-home message. It all depends where in the pathway the genetic mutation is impairing the synthesis of these hormones. And again, I'll explain on the next slide. So CAH can be caused from a deficiency of an enzyme called 21-beta hydroxylase or 11-beta hydroxylase. And I'm highlighting those two because those are the two that I highlight on my next slide. Before I go through the pathway and challenge you to map the disruption of the pathways, this picture is showing you a newborn baby girl. Notice the hyperpigmentation. Notice that her labia majora are fused. It looks like she has a scrotum, and her clitoris is enlarged. It looks like she has a penis. So when this virilization occurs to a baby girl in utero, it means she is technically a female, but she's developing male external genitalia. So they have virilized. And I'm going to explain why this happens in just a moment. Don't worry, once we address this CAH, if it is a female infant that has this genetic disorder, we can treat the problems. Her major problem is that she will have hypocortisolism. That's our biggest concern. If we get the cortisol levels back up, her hyperpigmentation will go away. I expect you to figure out why. It's a negative feedback loop. And we can resolve the changes to her external genitalia with some easy cosmetic surgery. Her fertility levels will not be impacted at all. So dare I say this is almost an easy genetic disease to address. So let me take some time to talk about why the virilization happened in this little girl. And let me also address why, if there is a problem, a destruction of the adrenal cortex in a woman that's not a genetic disorder, maybe it's some sort of virus that has attacked her adrenal cortex. Why do some women get masculinization and facial hair known as hirsutism? Let me explain on the next slide. So first of all, I want you to know that remind you that there are 3 layers to the adrenal cortex. And as I told you before, the outer layer, the zona glomerulosa, is the layer that makes our mineralocorticoid. It's a multi-step process. It all begins with cholesterol. I'll remind you from the first segment, steroidal hormones are derived from cholesterol as the precursor. So cholesterol enters these cells, and they have enzymes that convert the cholesterol from one hormone variety to the next. Shown here, 21-beta hydroxylase converts progesterone into 11-deoxycorticosterone, and 11-beta hydroxylase converts 11-deoxycorticosterone into corticosterone, which in turn gets converted to aldosterone. So if a person has a 21-beta hydroxylase gene mutation or 11-beta hydroxylase gene mutation, then these steps cannot proceed. We don't see those steps happening. The enzyme is missing. So this patient would not be making aldosterone. Okay, Well, that can be easily addressed by telling them to watch their salt and water intake and also watch how many foods they eat that are high in potassium. Okay, so cholesterol, if it could talk to you, would say, well, fine, if that pathway is broken, I'm going to jump over here to the middle pathway where the zona fasciculata cells are. And this enzyme 17-alpha hydroxylase will take pregnenolone and turn it into a different kind of pregnenolone. And then it goes through this pathway where, again, 21 beta hydroxylase is needed to convert 17-hydroxyprogesterone into 11-deoxycortisol. And again, 11 beta hydroxylase is used in this pathway to convert 11-deoxycortisol into cortisol. But that is going to be blocked if there's a genetic mutation. So now cortisol is missing. And that's the hormone that obeys the official HPA pathway now, isn't it? Draw the disrupted pathway. Can you understand why that infant now had hyperpigmentation? So cholesterol now only has this pathway to be shunted into, the androgen layer. That's the zona reticularis. Notice to get the DHEA and androstenedione, these are both male androgens, male steroid-like hormones, those levels keep going up. That's the only pathway available for the cholesterol. So now we understand why that female infant had the virilization. She was having too much of the DHEA pathway, having the cholesterol pumped into it. Now, if these pathways become disrupted later in life in a woman, she can still have masculinization. She won't have virilization because it happened later in life, not in utero. So she might have a more chiseled jaw. She might have a more muscle tone, looks really cut. I actually had a student that had a problem with the first two pathways later in life. She was beautiful, very nice muscle tone, chiseled jaw, beautiful. And she shared with the class how she had gotten sick and these first two pathways were disrupted in her. She had some masculinization. She took care of the hirsutism, the facial hair, by getting it waxed, obviously. But if we think back in time before we knew about these endocrine disorders, there used to be in the circus act the bearded lady, right? The bearded lady. And she had hirsutism. Turns out she had a problem with these pathways, and the only pathway left was the androgen pathway. There are test questions about these disrupted pathways, so again, I would review them before you take the quiz. Now we're moving on to growth hormone, also known as somatotropin. The target cells, organs, etc. for growth hormone, like thyroid hormone, are many. The biggies, though, are fat, skeletal muscle, bone, and liver. The growth hormone does follow a traditional axis, an HPL axis. Growth hormone is released from the anterior pituitary, and you will find out in just a moment that growth hormone by itself is not enough to have proper growth of your skeletal muscle and bones. The growth hormone is primarily released when you sleep, so it's true that you grow when you sleep. It follows a circadian rhythm, and this is the reason why when toddlers and teenagers, which are the two biggest populations that have the most accelerated growth, I mean, they really are growing in their sleep. They do sleep a lot. That is not the time to get on the teenager about how much they're sleeping. If you want them to grow, you let them sleep. This HPL pathway, just to quickly highlight it, the hypothalamus releases growth hormone releasing hormone onto the anterior pituitary, telling it it's okay to release growth hormone. Why would it say it's okay versus not? Somatostatin is another name for that, is growth hormone inhibitory hormone. Well, let me just quickly say there are times in your life where it's not appropriate to grow. Growing takes a lot of energy, a lot of fuel resources. And sometimes it's not a good time to grow. And I already alluded to this earlier, especially when it's a young child that is in a situation, maybe they're being physically or mentally abused, chronic stress. So under healthy conditions, growth hormone releasing hormone tells the anterior pituitary to release growth hormone. This growth hormone will target bone. It will target skeletal muscle, shown down here. It will lead to increased blood glucose levels. Growing takes fuel resources, so it's going to be a diabetogenic effect. But growth hormone will also target the liver, as I mentioned earlier. And the liver, in turn, is going to release another chemical signal called insulin-like growth factor type 1, also known as somatomedin C. So those different names, but it's the same chemical, same hormone. And that's going to target cartilage, especially in your epiphyseal plates. Increased cartilage production means lengthening of the bones. So tremendous rate of growth, bone lengthening. Again, here are the primary targets for growth hormone. I already told you about skeletal muscle. Obviously, skeletal muscle needs to get bigger when we're growing. So there's going to be more amino acid intake and more protein synthesis. As we age, growth hormone levels go down, and this is the reason why we see muscle mass goes down in the elderly. Adipocytes are another target for growth hormone. You heard me say it takes a lot of fuel resources for growth. So we're going to see mobilization of lipids. The body is going to use fats as an alternative fuel source. Growing takes energy. We're also going to see bone being targeted by growth hormone, leading to more cartilage production, lengthening of the bone, especially at the epiphyseal plates. And if we have too much of it before the epiphyseal plates close, we can see gigantism. So shown here is a very famous giant in The Princess Bride, Andre the Giant. But there are other examples of gigantism from people having an overproducing anterior pituitary tumor, the somatotropes. Somatotropes are the cells in the anterior pituitary that respond to growth hormone releasing hormone and make growth hormone. Another giant, the Alton giant in England, also had an anterior pituitary over-secreting tumor that led to excessive growth before his epiphyseal plates closed. Another famous one, the Irish giant, Charles Burney. You could read about him. He was in the late 17th century. So these giants grow, again, before the epiphyseal plates close. Now this woman in the picture, bottom right, she has excessive growth hormone, but this tumor developed after her epiphyseal plates closed. So she has acromegaly. She has appositional growth. Her bone is getting thicker, not lengthening in height, it's increasing in width. So notice her pronounced brow of her frontal bone, her pronounced mandible. If you looked at her hands and feet, the bones in her hands and her feet would also be wider, so her hands and feet would be bigger. In fact, people who have this type of tumor later in life, the number one thing that drives them to seek medical help, because it takes them a while to figure this out, all of a sudden they can't fit into their shoes and they're buying a brand new pair of shoes almost every week because their bones are growing so quickly. The liver is also a target in more than one way. Growth hormone tells the liver to participate in gluconeogenesis. Again, this is going to lead to a diabetogenic effect. Growing takes a lot of energy resources, so we're going to see mobilization of the proteins and lipids, not only to use them as fuel sources, but also for the gluconeogenesis. Okay. Now, these individuals, two different populations. Up on the top picture, we're seeing the Laren dwarfs, and then in the bottom picture, we see the African pygmies. Both populations have short stature. The African pygmies shown in this picture are adults, and they're standing next to a 6-foot adult male. You can see they're about half his height. Both of these populations have normal growth hormone levels. Yet why do they have short stature? I said growth hormone by itself is not enough. We have the HPL pathway. When growth hormone is released from the anterior pituitary, this stimulates the liver to release insulin-like growth factor, also known as somatomedin C. An insulin-like growth factor type 1 in the adult, also somatomedin C, targets bone and cartilage, making them mitogenic. That means the chondrocytes, chondroblasts, osteocytes, osteoblasts have increased mitotic rates. That means more cartilage growth, more bone lengthening. Without insulin-like growth factor type 1, then you're not going to have this proper mitogenic effect. Again, growth hormone by itself is not enough. In the case of the African pygmies, like I said, they have adequate growth hormone, but their liver does not produce insulin-like growth factor type 1. They are just not capable of making it and releasing it. In the case of the Laren dwarfs, however, again, they have normal growth hormone, but their problem is they lack a functional receptor for growth hormone. So if you don't have a functional receptor, then the target cell won't behave appropriately. So in the case of the liver isn't getting stimulated by the growth hormone appropriately, and therefore the liver cells do not make and release the insulin-like growth factor. For the African pygmy, this is a genetic issue, but for the Laren dwarf, a genetic issue not being able to make insulin-like growth factor. For the Laren dwarfs, their genetic issue is a mutation in the gene that codes for the growth hormone receptor. Their hepatocytes could make insulin-like growth factor type 1 if they just could respond to the growth hormone appropriately. Now, here is a good chart to know some overall responses of target cells like muscle, liver, adipose tissue, and overall what will happen to plasma glucose levels. I talked about cortisol and growth hormone in particular. FA stands for fatty acid. TG stands for triglyceride. You should already know from your physiology class what epinephrine does in the body, but again, here I'm highlighting its effects in these target cells. We will talk more about insulin and glucagon at a later date, but you should have also learned about insulin and glucagon in your human physiology course. Again, I would know these effects for these hormones before you take your quiz or your test in lecture unit 1. The last hormone I want to address is parathyroid hormone released by the parathyroid glands. The primary role of parathyroid hormone is to regulate calcium levels in the body. Now, this slide says that it's from chapter 79, but that's not from your pathophysiology text. Some of you might be using your Guyton and Hall text, because I said on the syllabus you could use that. So if you're using Guyton and Hall, it's from chapter 79. If you're using your Porth Pathophysiology or some other pathophysiology text, you're going to have to look up the chapter for parathyroid hormone. So calcium is the electrolyte being manipulated by parathyroid hormone, and calcium comes in a variety of forms. It can be bound to proteins in your plasma. It can be bound to negatively charged molecules, anions, or it can be floating in your plasma in an ionized form. Regardless, calcium levels in your plasma are the primary triggers for parathyroid hormone release. So that means parathyroid hormone follows a humoral mechanism. The parathyroid gland has cells called chief cells. They have receptors to monitor these plasma calcium levels. When calcium levels go too low, parathyroid hormone is released, and it targets bone, the kidneys, and your intestines. And I'll expand on that in just a moment. If you are not having adequate levels of calcium in your plasma, you have hypocalcemia. If you have too much, you have hypercalcemia. If you have hypercalcemia, you will have if you have hypocalcemia, you will have increased nervous activity, more action potentials, and as a result, more muscle contraction. And the reason why is, if you remember, there is a somatic motor neuron that targets your skeletal muscle. It releases acetylcholine onto your skeletal muscle. If your somatic motor neuron fires more action potentials, more acetylcholine is released, and therefore you get more skeletal muscle contraction. That means tetany. If you have hypercalcemia, you don't get as many action potentials, and that means the skeletal muscle isn't stimulated as much, and you get a decrease in muscle tone. Why would reduced calcium in the bloodstream lead to overexcitation of the somatic motor neuron, nervous tissue in general, and in turn lead to more skeletal muscle contraction? And the answer is sodium voltage gated channels. Sodium voltage gated channels have an external binding site for calcium. And when calcium is around, it stabilizes the sodium voltage gated channels, making them less likely to open. So they stay closed more often. That explains why if you have too much calcium, the sodium voltage gated channels would not open very often at all, and you would not get skeletal muscle contraction appropriately. If, however, you don't have enough calcium in your blood, then that external binding site is not populated, and that means the sodium voltage gated channels open, and you get very quickly and easily, and you get a lot of sodium coming in from the action potentials and more skeletal muscle contraction as a result. We will talk about this concept more in a different lecture, so I would remember this. Lastly, I want to address the actual actions of parathyroid hormone on the bone. Bone osteoclasts respond to parathyroid hormone, and this leads to more resorption of the bone matrix. And if there's more resorption, then more calcium is released from the bone matrix, called calcium hydroxyapatite. The kidney also responds to parathyroid hormone, and the nephrons will increase the amount of calcium reabsorbed from the filtrate. That means less calcium in the urine. The kidney is also part of making the active form of vitamin D. The active form of vitamin D is very important in order for parathyroid hormone to do its function. So think of vitamin D as being a permissive vitamin for parathyroid hormone activity. The intestine also responds to parathyroid hormone. Membrane transporters respond to this hormone to increase the amount of calcium absorbed from the food you ate through your intestinal lining. So again, vitamin D, think of that as a permissive molecule. Vitamin D, we can get precursors from endogenous precursors that are found in our skin, and they have to be somewhat activated by sunlight, or we can get it from our diet. This vitamin D that isn't active yet goes to the liver and becomes chemically modified, but yet again, it's still not technically active. It's still not converted to a form that can actually help parathyroid hormone do its job well. It has to go to the kidney and be chemically modified again to this 125 vitamin D variety, calciferol, dihydroxycholecalciferol. And again, you should probably know this pathway before you take your quizzes. And parathyroid hormone, along with the calcitriol, or 125 dihydroxycholecalciferol, will target bone, the nephron, and intestine, and lead to increased plasma concentration of calcium. All right, that concludes our lecture for the endocrine system disorders.